I will show to you tomorrow this concept of early placement with counter-augmentation. And this is one of the treatment options you have. I'm not doing all cases like this. I will show tomorrow because there you have different options. But most often we do this early placement protocol with counter-augmentation. Very stable results. Now we come to the third discussion. I said today we're going to talk mainly about standard implant placement. That means implant placement into healed sites, not post-extraction sites. And before we do that, I want to try out if my remote control works, because my friends, yeah, it's beautiful. And I have been asked again to show the QR code of our Facebook site. I have seen that more than 50 people have signed up. So we are growing there, the community. And now I want to see if this works. Yes, it seems to work. Okay, what a nice toy. Thank you very much. Okay, so if you want to sign up, you take a picture and then you will find the way very quickly. Okay, now the topic, posterior sites, healed sites. And the posterior mandible, that's about 30% of our daily business, where we place implants either in premolar sites or molar sites. And I will show you how this is done. So the question is, when do we do that open flap? When can we do it flapless? And flapless today is most often done with computer-assisted technology, also digital technology. We have a digital transformation of our profession. It's not even a question. And of course, we have here lots of young people. And of course, that's where you have to focus on. It will not mean that in the future everything is done with digital, and of course not everything is done flat. It's impossible. But digital technology in the future will help us to further simplify the procedures, make the procedures probably less demanding for the patients. So it's a very nice improvement for the secondary objectives what I'm talking about this morning. Okay. Posterior mandible. You can have healed sites, but you can also have, of course, an extraction site. And I will talk about that then tomorrow as well. So you have a first molar extraction. I do often today. I will show that tomorrow. I'm going to do often today socket grafting, and then we let it heal to allow then flapless implant placement with computer-assisted surgery, particularly in elderly patients. But we often also have healed sites. That means extraction has been taking place many years ago or months ago, whatever, and then you have often atrophy. When I show that to you here, yes, this bone is very narrow. And then, of course, when you have these kind of borderline situations, you have to check out how is the shape of the mandible. Is the shape like this? Meaning when you cut down the crest by 2 millimeters, the width is improving. That's a very important point. Is the shape like this? Not often. Sometimes the shape is like this. Undercut. Very dangerous. Because you don't want to drill into the floor of the mouth. Because most of the fatal complications and patients have been drilling into the floor of the mouth, cutting into a blood vessel, the patients start to bleed heavily, and the tongue swallows, and then boom, patients can die. Very dangerous. Have to be brave. So when we analyze patients in the posterior, we need to know what are we dealing with. So first is always a clinical examination. That means you take your finger, feel the undercut. Is there undercut on it? Take the finger on the other side, how is the shape of the mandible? You feel on the top, is it narrow, is it getting wide? You check the keratinized mucosa. When it's a borderline case, then you take a 3-dimensional radiograph. If it's nice, wide, then panoramic radiograph is sufficient. You don't need then a cone-beam CT. But both is possible, depending. What we want to know, you see from the radiographic analysis, is we want to know how are the adjacent teeth. Are the next teeth in good shape? Are there problems? Second, of course, we want to know the width of the crest at potential sites. Where is the mental foramen? You know, the nerve comes out with a loop. So where is the nerve? Where is the canal? And the undercut. And of course, you want to know, is it like this or is it like this? So these are all the parameters you need to know when you place implants. And okay, we have analyzed multiple studies with cone-beam CTs, the anatomy of the mandible, of the maxilla, of the anterior maxilla. This is the paper on the posterior mandible. And this is actually done with the teeth still in place. So assuming that we would have to do an extraction, what do we have when we do the extraction? And you see the results, and we have analyzed very intensively. Svetlana Braut is a female colleague, an ITI scholar at that time. Today she's member of the editorial board of the ITI Journal for Implantology. Very smart lady. She's from Croatia. Back home now, she's running a study club and she's moving up the ladder in ITI hierarchy. And we analyzed, and what we found is the following. We found that the facial bone wall at extraction sites in premolar sites most often reduced in height and very thin. So that means it's not a really good situation. Older sites it's different. Older sites it's a much better. Often it's a very thick. When you look at this number, you see red means missing bone. Here you see green would be intact bone thick. That's not very often, that's 30%. When you go to molar sites here, that's much better. It's more than 50% thick. Very good. Okay, the second one is, and that's more important, that's the height. The height. So when we move to the alveolar height in the posterior mandible, the teeth still intact. That means the height above the canal is always good. That means, you see, when you do extractions and you let them heal, you're going to have more than 10, 12, 14 millimeters of bone available to place here. And as you will see later on, here you see the numbers, around 14 millimeters. Very good. That means when we put an implant in and the ridge is like this, I can always afford to reduce the bone a little bit to get better width. No need to do vertical bone augmentation because vertical bones are very difficult, not very predictable. We all know Istvan Urban, a fantastic surgeon, very good friend of mine, but what he's doing, that's not for Dr. Joe average. It's for a few people, but most of them it's not even needed to a vertical ridge augmentation. And you cut it down to improve the width. That's how we do that. But this study is very important to show that the bone height is not a problem. The bone height is only a problem in the site, where this has been taking place extraction years ago and the patient has been very partial removable denture. Then the denture destroys the bone and then you have this saddle type defect. But that is 1% of our patients, very rarely. We are doing a lot of cases. We have one case in such a disaster situation per year. That's not very often. Okay, we go ahead. Now, I showed you this slide before. The basics of implant surgery. And the first point we have already discussed, the selection of an implant type which is appropriate. Now we're going to talk about the second and third and fourth point. That means put the implant in the correct position, make sure that the implant is fully embedded in bone, 360 degrees in the bone, and that's a very important point. The smoothing of the crest. This case is more than 20 years old. This was done when we had these SLA type implants the first time for clinical study. It was 97, 22 years ago. And you see, all these are premolar molars. So we cut down the bone, as you can see, it's flat. And then, as I said, you see, make sure that this is very thick here, very thick. And where the implant border between smooth and micro rough has to be 1.5 millimeters at least to have stable bone after healing. Very important take on this. Okay, then you select based on the width. Okay, and when you measure the width, then you make a decision what implant diameter you can. Standard diameter. Then you make a decision what diameter of the implant is needed to keep this thickness. Standard diameter, narrow diameter 3.3, very rarely 2.9, or wide diameter. When you have only, let's say, not much height, often the ridge is very wide, then you can use the wide diameter implant, which is 4.8. The core diameter of 4.8 is 4.2. That means then you need more than 7 millimeters of width of the crest to allow a 4.2 millimeter implant to have these thick walls on both sides. Okay, here you see this patient that was referred to me. You see that we have cut it down nicely so it's very flat now. And you see here, sorry, I have both here, okay. What we always do, check the height to the occlusal surface, because you need enough height for your crown, abutment and crown. Today, most often, we are using screw retained restorations, and the abutment and the crown is together in one piece. Often done with CAD/CAM technology, all ceramic single crowns. And so you need a 7 millimeters of height. That is a very good one. If you see it's very tight, you have to put the implant deeper to have more space. That's a very important one as well. What we often do, you see, we prepare an implant bed, of course, stepwise, which is a low trauma technique. First, round burr. We check the position. Second round burr. When needed, we can correct the position a little bit. Then the first spiral drill, and the first spiral drill goes in place with a depth gauge. If I see, I want to know where is the nerve, I take a radiograph here. I do that in about 50% of my cases. Periapical radiograph to check the depth. You see on the radiograph, of course, your depth gauge. You can see that the depth gauge here. Sorry, that's the wrong one. Here. Depth gauge is cut down. So you can put in a radiographic film holder. Take the radiograph, reconfirm, and so on. And then we go ahead with the next spiral drill. We expand. We can check slightly axis, we can correct everything if needed. So very precise, like this. Okay, another one is, you see, atraumatic surgery does not exist. This is a nonsense, this term. There is no atraumatic surgery. But what you can do is a low trauma surgery. It's always a trauma. You need actually for healing, you need a trauma to the tissue, otherwise bone is not going to heal. But don't overheat, for example, the bone. The blood vessels should not be heated, otherwise they will not heal. So therefore we are using a drilling machine that has a reduced drilling speed. This is my favorite one. This is from a Swiss company called BNA, iChiro Pro. So here you have a perfect control on your speed. So you see there an iPad, and the iPad shows you what speed you are working with. You see, when I do the operatory, they put in at the iPad Professor Busser, and then I have all settings of my surgery. Somebody else, Dr. Meyer, he wants to have a different setting, he can have a different setting. So what I normally do, I use a setting of 1200 RPM, 800 RPM, 500 RPM. That's for the drilling sequence. First higher speed, then slower speed, low speed. And when we put the implant in, it's 15 RPM, very slow. That's for the pre-tapping and for the implant insertion, without any cooling. When we drill the bone, we need the cooling, of course. And you see this is attached to the machine, and the cooling is done with chilled saline. That is from the fridge, sterile saline, so it's 5 degrees centigrade. We have done it in the late 80s, long time ago. We measured in the bone how the temperature of the body develops. When you drill a hole without any cooling, then of course goes up. We know 48 degrees is disaster. All the blood vessels get coagulated, and then actually there's no healing. But when you take a 5 degree centigrade, you see 5 degree cooled sterile saline, the temperature of the body goes from 36, 37 to 32, goes down. Very effective technique. And this can be done with this machine beautifully. Okay, so we check, this is the radiograph. So I see there, you see the this is the 6 millimeter mark, 8 millimeter mark, 10 millimeter mark. When I put a 10 millimeter implant in, the preparation should go to 12 millimeters. So I see the 10 millimeter mark is below the crest. Very important. So we check. Here I took the radiograph to make sure that we are not getting too close to the adjacent root. Often I do it to check where is the nerve. So that depends what we have. Okay, now here you see that the implant bed has been completed. You see the 10 millimeter mark is not visible anymore, it's below the crest. And then we put the implant in. You see the implant is now in place. And you see this is a tissue level implant. And the tissue level implant has a 2.8 millimeter machine surface. And you see the implant shoulder is about 1 millimeter above the crest. So I'm 1.5, 1.8 millimeter below the crest. I don't care if I get a little bit of remodeling. That's actually what I want to have. But I don't want to get my micrograft surface outside the bone. It has to be inside the bone, protected by osseointegration. Okay, what we also do, we normally take the measurement of the stability. Primary stability, I'm not using this insertion torque value, because an insertion torque value is a single point value that cannot be repeated later on. This technique is called, you see this is resonance frequency analysis. The machine is called OSTEM. It's a Swedish development and the technique I will show to you later, the literature, is now owned by I think a US company. They bought it. This technique I love because you can measure the stability and you measure again 4 weeks later, 8 weeks later, 12 weeks later, whenever you want. So you can have repetitive measurements, a longitudinal documentation. You can show how the healing progresses. And that's why we take the measurement here. So here you see again that this is inserted. You see the micrograph surface goes below the crest, as shown here. This is what we always do. At least 1 millimeter, 1.5 millimeter, depending on the width. You see, when it's very wide, then you don't have to go very deep. If it's more like this, I put it deeper, because you get better thickness the deeper you go. Okay, we go ahead. Then the healing cap is positioned. And then we go for a so-called non-submerged healing, also an open healing. Why do we do that? Because you see, the open healing gives you the chance that there is no reopening procedure for the patient. You'll eliminate the surgery. Do I always do it like this? Yes, in a posterior mandible most often. I'm not doing that in fully dentures maxillas, because when you put a full denture on, there's a certain risk to get these implants destabilized during healing. You have to be very careful. But in a posterior mandibular side, with the standard placement, no GPR, nothing, I go for non-submerged. That's the original ITI approach. You see in the post-surgical radiograph, you see beautifully that we are below the crest. On the mesial side, the implant shoulder is almost 0.5 millimeter above the crest, on the distal slightly more. And you see that where SLA starts, that's where the internal configuration goes into the curve. That is clearly below the crest. So when it heals now, when the crown gets on top later on, then of course you're going to get a little bit of remodeling around this machined neck, which is no problem, because 10 millimeters will be osseointegrated, slightly more maybe. This is an investment into the future stability of that implant. That's what I showed you before, very important, the 1.5 millimeter part measured where the SLA starts. Okay, that we have seen before, and I told you that it's important that the crown to implant ratio is all, but that doesn't play a role. And these are the complicated. Here you see then the patient at 4 weeks. At 4 weeks we measure again ISQ. And then you see the ISQ is 80, very high value. So at 4 weeks, most of the patients here get a green light, we can do the restoration. So they go straight into final restoration. There's no need for provisionals. And so it's actually a very cost-effective treatment. But patients wait 4 weeks, most often. Okay, here you see what was done in private office. This is the single crown done by the GP who sent the patient. Here you see the radiograph. It's a screw retained from final crown on top. This is the 4 years follow-up of the same patient. Patient is now almost 80 years old, so soon, and he's doing very well. I know the patient very well because I did on that patient in the upper jaw implants 12 years ago. So he has in all 4 quadrants, he has now implants to support his masticatory function in the posterior side. So actually this implant is doing excellent. He has only a second premolar occlusion because he has only a second premolar in the upper jaw. That's why we did not place more implants. Okay. This is the healing periods we are using. This is based on an ITI consensus conference in 2008. It was published by Dean Morton and colleagues. That was in Stuttgart, in Germany. And you see that these are the terminology we are using for the loading protocols. We are using the term, of course, immediate loading, which is within a week. Then we have a term called early loading, which would be everything from 2 weeks up to 8 weeks. But that's not very logical for me. So I would say when we do an immediate loading, for me, it's a day of surgery. Not often we do that. I'll show you tomorrow a case where we did it. Second one is, early loading would be either at 4 weeks or at 8 weeks. So that's very easy to communicate with your patient. You tell the patient, look, this is a site, I guess we can do 4 weeks of healing, so a month. We measure the stability. If ISQ is 70 plus, then we go ahead with the final restoration. When it's not 70, we wait another 4 weeks to 8 weeks. When it's not 70, we wait another 4 weeks for 12 weeks. That's very rare. We are using the same for post-extraction placement. We use the same for implant placement with sinus renovation, where in about 80% we can use 8 weeks of healing. In this kind of cases, 4 weeks is the routine, because this is a healed site. And that's very interesting. Why can we go so fast? That's because of the surface quality of the implants we are using. University of Bern has been involved with surface research for 30 years. That was the first topic of my research career. And you will see soon in a publication where we analyzed 30 years of research support through ITI Foundation. More than 400 studies have been supported by ITI Research Foundation. And one of the first ones was actually a study by our team on this surface technology. And the result of that was the so-called SLA surface. And that was in 1997 we started the clinical testing and so on. And then in 2004 we had then the results of a preclinical study, that means a study in animals, available on the so-called acelactive surface. When we did this research in surface technology, first the topography of the surfaces was altered and optimized. How rough should it be? And you see these pits here and this very fine structure. And then in the second phase, we also changed the surface chemistry. We changed the surface from a hydrophobic surface to a hydrophilic surface. So the blood has a better access to the surface from day zero. That was the big trick. And it was done in animals, in mini pigs. And so, and here you see all the publications from this activity in the early 2000, 15 years ago. And you see the first one is on top, the Buso Broccini colleagues. 2004, published in Journal of Dental Research. It's the best cited paper supported by ITI Foundation. It has about 45 citations per year, which is a fantastic number. That helped a lot to bring Bern up in the ranking, these kind of publications. And that study showed that bone is very quick in healing when you have a hydrophilicity. Very quick. Okay. In clinical practice, however, you need to measure the stability. That's what I told you before. We are using this resonance frequency analysis by Dr. Neil Meredith. He's an English colleague, very smart guy. And he established that together with this Ostel company, and so on. This technique is 20 years old, but it has been improved over the years. So it was the first generation, second generation, third generation, now it's fourth generation, where you have an app. The measurement goes straight to your cell phone. You can see everything, but this is just technology, visual technology. And here you see how this is done. This was part of the study we published 10 years ago, because there we loaded these implants at 3 weeks of healing. Very quick. Today, we normally do it at 4 weeks or 8 weeks because we want to have these monthly intervals. It's easier to communicate with patients. But you see, healed sites, nice cases, of course. We did not do them flapless. Today I will do all these cases flapless, I'm sure. Small flaps, smoothing of the crest, implant preparation, insertion of implants. normally. And then you see here, that's the typical for this hydrophilicity. Look here, these implants are wet. That means Straumann, when they produce these implants and they get this surface, it is a sandblasting process and it's an etching process with an acid etching. So the sandblasting produces the roughness like this, and then the acid etching these small pits, the small characterization. When you take that out of this treatment, then of course you have to rinse it with lots of water, sterile water, to get rid of the acid from the surface. And then of course you have a hydrophilic surface. Then when you take it out like 20 years ago and let it dry in the air, you get a hydrophobic surface. Because this titanium picks up ions from the atmosphere very quickly. So if you want to keep it hydrophilic, you keep it, you leave it in this sterile water. Nitrogen chloride, very simple, very smart idea. You know, many good ideas are very simple, but first you have to have them. So they keep it there, so you get it actually in these vials, and inside is sterile natrium chloride. So then you put them out, put them in, and have a hydrophilic surface. Okay. Then the ISQ is measured. It was very high, which is very normal. When you put a 10 millimeter implant in a weak size and you do a precise implant preparation, I would say the ISQ in the mandibular case is between 72 and 82 about. So this is at the higher end with 80. Okay. So then a non-submerged healing, and then 3 weeks later it looks like this, a very quick healing. And then we measure ISQ again. So a slight increase to 83, and then the patient, as part of the study, got then immediately a provisional crown to get the loading on top. Right? But of course, in clinical practice, that's a little bit different. But these patients sent back to the referring dentist, they take an impression, and then it takes normally a week to get the crown back by the technician also. Today, when we talk about the digital technology, it's improving again. I will explain to you just in about 10 minutes. This is a maxillary case. In the maxilla, the bone density is normally not as good as in the mandible. So the ISQ value is slightly less. This is 70 here. Same technique. Healed side. And you see at 3 weeks, ISQ is now 72, so it's above 70, so we go ahead. We took an impression, a week later the crown was finished, ISQ is now 77, increasing because of the progressed healing. Okay, then you see here the crown seated, at that time cemented, when you look very carefully. See, sorry. Sometimes a little slow. Here, look here, see the remnant of cement? I had to take it off. Today, I tell you, frankly, in 10 years, I've not done one cemented crown. We go for screw retain. But of course, has to do with the CAD/CAM technology that we have. Because when you do CAD/CAM technology, that means we do a monolithic crown, everything produced. Then we glue it to the abutment. And then we get the crown in one piece, goes inside the implant, and then we do a 35 centimeter fixation with a screw, and it's down the implant. So it's no risk for cement remnants. So that's, we completely abandoned cementation in our clinical practice these days. Okay. How did we study that? You see, we studied with 2 clinical studies and the early documentation. You see, one was here, the paper by Bornstein. Michael Bornstein is now a professor in Hong Kong, and was a student of mine, and there he's radiology professor. He's a very good radiologist these days. The other study was done in Florida by Dean Morton, who is now a professor in Indiana University. So both of them made a big career. I show you quickly the paper published 10 years ago. This was a short-term documentation. Had only 6 months. We wanted to show how are the ISQ values developing over time. So we had in that study, as you can see, we had 56 implants placed. It was a prospective case series study, non-controlled. And you see then that during the healing phase, we had no implant failures. We had 2 slightly spinning implants at 3 weeks, so we had to give them more time to heal. And of course, we measured ISQ for all of them. And you see here, these are the ISQ values over time. So you see that at day of surgery, as a day 0, the average was about 74. But you can also see here, you see that of course some of them were 58, up to more than 80, that's the whole spectrum. And then we measured at 3 weeks, 4 weeks, and then 7 weeks, 12 weeks, and you see that the curve goes up. So, very nice. And based on that one, we made a decision. We want to use in daily practice a threshold ISQ of 70. That's just universal birth threshold. Other people, they say 65 is enough, others want to be more than, they say 75, I don't know. We are using 70. So when we want to give a green light to restore an implant, we take an ISQ. If it's not 70, we wait. But that's only for stronger type implants. There might be other values for other brands, I don't know. So when we look at these local protocols, in standard sites, posterior, no bone grafting, 4 weeks is today our standard healing period. That's more than 90%. We can use 4 weeks of healing, which is very attractive to patients, very quick. Okay, these I have shown you already that if you want to optimize the thickness of the facial wall, you can do that with these narrow diameter implants. This is a repetition of this morning, so we don't have to discuss too many details here again. You see, we do the same. When it's a smaller diameter, I'm a little bit more careful when we load. So we take measurements as well. First pre-bolus. Sometimes they do shaky, then I wait 6 or 8 weeks to be more on the safe side. So this has not been studied in a study like the standard diameter implants and so on. Here you see this lady. I mentioned that she is almost 90 years old at surgery, and now she's 4 years down the road. She's now 93 years old. She's getting older and older. We have a lot of patients getting 100 plus. When we talk about demographic changes, so today these specialists say when people get 70, that I know about the percentage of, in particular female patients, that they get 100 plus is a very high percentage, because the progress in medical and dental field is so much that patients get much, much older than 50 years ago. In Switzerland, all the numbers today, the average life expectancy is for females is 87. And 100 years ago, it was around 45 years. It almost doubled. It's amazing, the progress in that field. Okay, now what about flatness? And what about implant with using computer-assisted implant surgery? So we are in a phase of digital transformation. And of course, some of you might have heard, you see at the Cologne was the International Dental Show, IDS, every 2 years. Now you see, I'm not going to Cologne, I send the youngsters, and the generation Y goes to Cologne, including my daughter. She's a prosthodontist working at Bern, and they all go every 2 years to see what's the latest. She came back, my daughter, and said, yeah, this year a little disappointing, not much progress. 2 years ago was much more exciting. So it seems that the development is starting to flatten down, because the technology has certain limitations as well. But that's good. That means then we are getting into a phase where it will stabilize, and what we have to do now is we have to establish, you see, the evidence what really works in daily practice, so you know what you can use. Now what is important for tissue transformation, you see, it was first initiated by 3D radiology. Very important. You see, the dental CT in the mid-1990s did not really help, and radiation exposure was quite high for that. But then late 1990s, early 2000s, the cone beam CT came to the market, and that really triggered the progress in that field. And as I showed you, in 2004 we started with cone beam CTs using a Morita machine, Aquitomo. Of course, over the years we have seen a tremendous progress with the quality of Morita's machines and others, of course. Second step of progress, that was the possibility that we can take a digital scan. So 10 years ago we normally took an impression and put them into a scanner in the lab, and they produced then the scan. Today now we have these scanners to do the impression intraorally, which is of course a huge progress for patients. I have seen many patients who had a lot of troubles with their gagging, you see, because of the impression material. So when you can do intraoral scanning, you see, this is a big progress for patients. But we all know, you see, this is perfect for single tooth cases. It's nice probably for a distal extension situation. It's still problematic for fully edentulous patients. That's not going to work as the same as the single tooth. Okay, and then the third step of progress was in the field of the software available. Now we can take the digital file of a cone beam, and we can take a digital file of the intraoral scanning and import it with so-called matching software. Sorry, I'm going backwards here. So, okay, that's very important. And so, this one we have seen, and of course this one as well, and that's what we do. When we do the scan, also the 3D radiology for computer-assisted surgery, we need to have enough occlusal surface to match it with the intraoral scan. So I would say the 4 by 4 centimeter volume is most often not large enough. So then we either take a 6 by 6 or a 4 by 8 to have enough surface from the occlusion. And of course it's important that the neighboring teeth are not all made of metal crowns, because otherwise you have a lot of distortion in your radiographs. So that can be a problem. Then when we talk about the digital intraoral scanners, you see, then there are different brands on the market. We are now using these days, we have used the iTero for many years now. We are using the Trios from 3Shape. It's a Danish company. Also have a good relationship with Straumann. And it's amazing, that's the Trios from 3Shape. This is a video clip, of course, a commercial, and they say insane speed. Look at him. How they take an impression. Often they show a video with a young boy, a young girl, 12 years old, taking impressions. And so, but it's amazing to see how you can take an impression. See, this is done always with my postdocs. They do that for me. So I normally watch. What I see is that the patients are blown away by the technology, because you take this